Okay, everybody, welcome. Welcome to this session. If you're, the rooms were a little bit confused, but we're in the pandemic session, so let's just all be careful. So we have 3 presentations today, and we're already running a little late, but anyway, we'll see how we're going. We've got afternoon tea after this, so we have a little bit of wiggle room, thank heavens. Our first speaker is Natalie Jones. And Natalie is going to speak to us about blending technology and creativity to adapt cognitive rehabilitation strategies for individuals with acquired brain injury. Thanks, Natalie.
Thank you. Well, this is my first time having a microphone on, so it feels very strange. So this is a very long-winded slide. It's not up there, though. Should it be? Anyway, just imagine it is. It looks wonderful. There we go. All right. So, about a year ago, I was walking down Merrickville Road trying to find a gentleman I had just transferred $50 to pick up a secondhand snowball microphone, which is sitting right here. I was not blessed with a very good sense of direction, but I found him eventually. The next step really was getting home, plugging it into my little 10.5-inch Microsoft Surface Pro and logging onto Zoom and recording my first ever podcast episode. So how is this different to probably the thousands of people doing that exact same thing at that moment? This man. This is what was different. This man has changed my life in a very big way. So I'm going to play a clip for you before I tell you who he is, and I want you to tell me if you recognize which show this comes from. This is going to be for Gen Xers and Boomers, and if you're not from Australia, I apologize. I didn't know either.
Got to tell your father to get that car thing fixed.
What? My father? Oh, no, this is my farm.
You run this whole place by yourself?
Well, I'll try. Well, thanks for your help, Dubber.
It is Molly. Yes, a country practice. Yes. So I don't know Ann Tenney, but I do know the gentleman opposite her, and his name is Glennon Fay, or Glennon Cece Fay, as he prefers to be called. Now, Glennon is a professionally trained actor, a very talented actor, and he began his career on stage, on film, and in television about 4 decades ago. So you might be asking yourself why I'm showing you all this, and how he went from being on the big screen to working with me. In 2007, December of 2007, Glennon was living and working abroad. So he had stopped acting for a while, and he was teaching English in Asia. He was standing up in front of his classroom very much like this, and suddenly his vision went completely dark. He didn't know what had happened, obviously. No one did. He was rushed to the hospital, and they discovered that he had suffered an aneurysm. So it was the result of an AVM, or an arteriovenous malformation, which is what you see up here. And I'll play the video in a second. But essentially what it is an abnormal tangle of blood vessels connecting arteries and veins. And because these blood vessels themselves are abnormal, they can weaken and rupture, so causing stroke, hemorrhage, and brain damage. So this is something that Glennon was born with. I'm going to play it so you can see. A lot of times it's likened to a bird's nest, but this is obviously the rupture. So it's quite dramatic. But this is what happened to him. So he was treated, stabilized, and brought back to Australia to be with his family. He was then scanned. I believe he was in Balmain Hospital, but he was scanned, and they found another 16 smaller aneurysms that were waiting to be discovered. And luckily, were discovered before something worse had happened. So it's very much a miracle that he's still here today. All right. Aside from experiencing cervical dystonia, so Glennon's neck tilts to one side, not all the time, but he has spasms and weakness in one side of his neck. This is really one of the main physical manifestations of the aneurysms. His impact has largely been cognitive, so around attention span, but most notably with memory. So Glennon has both retrograde and anterograde amnesia, which means he has a very difficult time remembering old memories, but he has an even harder time making new memories. And I liken it to the visual metaphor of basically someone's constantly running behind him with a giant eraser, erasing every new memory he's made, and he's running just slightly faster than they are. In therapy, I'm an occupational therapist, so I began working with him in 2019. We continued working on traditional memory exercises and activities, but it became pretty clear over time that we weren't achieving a lot of functional gains or meaningful gains for him. So COVID hit, as it did all of us, and it hit him in a big way because since his injury, he's been living in an aged care home because of his care needs. So he's had to endure much longer lockdowns. They're in a lockdown right now, actually, because a resident has COVID, and much more stringent restrictions because of that. So I had to really dig deep as a therapist and figure out how we could continue working together in a way that was more than just getting on Zoom and transitioning to telehealth. And then one day I thought back to all of this, about what his family had told me about his acting and his skills beforehand. And I thought, why don't we look at experimenting with a new way to target his goals? And so our podcast, 51st Episodes, was born. So essentially, it's inspired by the movie 51st Dates, where young Drew Barrymore has TBI and amnesia afterward, can't remember. So that is not untrue. Our slogan, 2 people host a podcast, only one of them remembers it. Because for quite a while, Glennon would forget that we would record episodes and often forget that we even have a podcast. But now, when I put this little mic out, he knows exactly what's happening. He points to it and he says, oh, we're doing that now. And then he knows how to plug it into my laptop, and he has this intro memorized. So he is creating new memories. And here is the recording.
First episodes where 2 people host a podcast.
And only one of them remembers.
He's got a wonderful voice for podcasting. So let me get to the next bit here. Essentially, each episode centers around a theme, which we spend about 10 to 15 minutes beforehand discussing. And UTS Open had an online course. I don't even remember. It's been a bit of a time warp. But they put this out as a template for people who want to, here you go, make your own podcast. So this is sort of the template we used. And it's been a really good tool for Glennon and for myself to be able to organize thoughts and memories beforehand, before we record. So there are other cognitive skills being worked as well. It's very good for planning. And often, it's interesting, we find that a lot of memories come out here. He doesn't often reference them when we record, though. So this has been a nice thing to prompt himself, in a sense. So essentially, the first part of the episode consists of the 2 of us chatting and recalling memories, and we both share memories because he'll often ask me the same question back, and I have to respond. So that format has been, by and large, what we've used to date, is just the 2 of us. So I'll play you a clip of one of our recent episodes.
Memories that come to mind?
Yes. I didn't like another guy in my class because he always picked on me. I thought he was worse off in his life than I was. Mm-hmm. And yet he chose me to don all his anger on. So I'm getting a bit emotional with that.
Do you recall his name or what grade this was?
His name was Robert O'Brien.
Robert
And
O'Brien.
he was what I called a pig dog.
Robert O'Brien was a pig dog. And if you want to know what a pig dog is, listen to episode 1 because he goes into a lot of detail. So there's the format of the two of us talking, and then we've since introduced family members and other people in his life to be able to prompt him. So we've got an episode with his mother, and we've got a few with his nephews as well, which is lovely because not only is it helpful for them to be able to prompt him in a way that I can't, but they can also corroborate his memories that he's shared from previous episodes. So I'll play you a clip of that one. This is just a wonderful picture. I got it from a while ago.
Best point of my wedding.
Yes.
The best point was when Uncle Glennon, he came up to my wife, newly married.
Oh no! What did I do?
He said to my wife on her wedding day, "You look like you've been at a wedding." And she stands there in her wedding dress. It was fantastic.
So you'll notice Glenn is laughing the loudest. So he's very aware that there's things he cannot remember, but he does have a very good sense of humor about it and isn't afraid to ask those questions of, oh, did I really do that? Did I really say that? So he's very, very good about that. So since memory is encoded in various parts of the brain and using all of our senses, we've started looking at incorporating other senses into triggering his memories. So taste, sight, sound, smell, we've looked at them all. Sort of an ongoing exploration of how we can get memories. And also looking at exploring, going on the road, so checking out places that he used to live and work, or people that he knew both personally and professionally, to be able to do more of the same of what we're doing with his family. So as time went on, I realized we weren't doing just a guided recall of his memories. I think we were giving Glennon a voice. I think we were and are still sort of reconstructing an identity for him as a different kind of performer. And we're doing it in a medium that allows him to go back and listen to it whenever he wants to, or whenever he can remember to. But it's actually very helpful, and it's something that we sort of stumbled onto. So I think as a therapist, it's important for me to look at the person, and what Tim said a lot this morning really resounded with me. But look at the person, look at their background, look at their interests, and things that are still relevant to them, and really, I hate to say think outside the box, but yeah, try things. And I'm lucky in that Glennon is so open-minded and flexible and good-natured that, you know, if we have episodes that we get a lot of memories, he's really happy with that. And if we get almost nothing, he's fine with that too. Both of us have that agreement where it's just it's something that we're going to keep doing as long as we continue to enjoy it. And I think that's what matters and makes a difference. And in the process, we've sort of been looking around for podcasts, and now that I've spoken to people in the lobby, I found that there are several. But I saw a lot of OT podcasts that were easy to find on Spotify and other mediums that were by OTs for OTs, or they were maybe interviewing clients, but I didn't find any that were specifically client created, or at least co-created. So I think that's what sets us apart, and I'm very proud of that. So the last part of the episodes are Ask Glennon, where I ask him or someone submits a question rather, and he gives a very straightforward, no-nonsense piece of advice. So the two of us, because I also have a background in performance, we improvise through the scenario or the piece of advice that he's given, and work through to some sort of conclusion. And the very last bit, I ask, one last piece of advice, Glennon, one last thing for anyone who's still listening to us. And sometimes he comes up with really insightful things. Sometimes he will really shock me, and sometimes he will say something that's completely ridiculous. But we both have a good laugh about it. So I'm going to leave you with one of my personal favorites from a recent episode.
and you know other people, and you ring other people.
No, that's not it.
If you know yourself,
Go.
and you know other people, and you ring other people, why don't you ever ring yourself?
Something to think about. So I want to thank you for listening. We are on Spotify if you'd like to listen to us further, or we try to record at least once a week or once a fortnight, depending on things that are going on. And yes, it's been a wonderful journey, and we hope to continue it. So thank you very much for your time.
Thank you, Natalie. What a beautiful idea. And I'll be listening to that on my way home tonight.
Some more flowers.
So thank you. We're going to move on now to Sky McDonald, who I know kind of well. Sky and I started working together a long time ago, and so it's a great joy for me to be able to introduce her to you today. She's going to talk about another really fun, amazing project called The Carer's Way Ahead, a new online resource to assist families of people with TBI, and it's about challenging behaviours. It's a training program for families. So over to you, Sky.
Thank you. On? Yes. Yep. Okay. Great. Hi everyone. Lovely to see you, and thanks for the opportunity to tell you a little bit about this program called The Carer's Way Ahead. I've been going to quite a few talks today, and including some really inspirational ones with people with lived experience telling us about their experiences, and in all cases it's the families that seem to be the backbone to recovery and support. This program is really for families. So we're sort of aware that with research tells us that more than 50% of people who have a brain injury will have long-term severe brain injury, emotional and behavioural problems, and families are vital to the progress of the person. And often they provide the frontline care when the person's in acute rehabilitation or in acute management, but also they're there in the long term. And often families can be the only source of support, particularly if it's someone in a regional or remote area. And as time goes on and the acute rehabilitation services fall away. And we know that for many families, difficulties in managing behaviour in the home can lead to isolation and distress and breakdown of the families and carer burden. And all that's, of course, associated with spiralling health costs. So we were interested to see how we could assist families. Now, this program I'm going to tell you about sort of has been developed with the help of some expert clinicians who do work with people with brain injuries and behavioural issues, and we know that work is incredibly valuable, but it can be expensive if people are paying for it out of their own pocket or once Medicare sort of leaves you behind. It's also limited availability, and certainly during COVID, I mean, a lot of psychologists have closed their books. Basically, there's just no capacity. A lot of these programs are city-centric, so there's a lot in the city, but there's not so much if you're outside of that. And also, a lot of these interventions require face-to-face meetings. Now, we have obviously all moved along with COVID, so tele-rehabilitation has come, but nonetheless, it's still a lot of tele-rehabilitation still requires like a time slot where you're available and the therapist is available. So how can we sort of expand the resources that people can get access to, and web-based resources are clearly a good solution. We know that web-based resources can provide a good structured approach to managing challenging behaviours, and the really good thing about web-based resources is that they're accessible. They're accessible provided you've got internet access in remote and rural areas. And they're also accessible for people who may be in the city but have trouble with mobility or access, or just simply have poor time time availability. So we decided to develop the Carer's Way Ahead. So the Carer's Way Ahead is a internet-based program, and it's based around 4 families. So it's a program that provides general advice, but it's sort of built around these 4 families that have specific difficulties coping with a person with brain injury. It was developed by a number of people who I'm really pleased to see many of them in the room. Sam Grant and Paul Gertler are clinicians who work routinely with people with brain injuries. Myself, I'm a neuropsychologist, so my background is in neuropsychology. Emily Trimmer is another person who was the project manager in developing it initially, but is also a clinician working with these issues. Graham Simpson's been invaluable for his background in working with families from a social work and psychological perspective. And Jill Newby is an academic at Black Dog who I work with, who's already developed some really wonderful resources for depression and anxiety that can be used on the web. So the Carer's Way Ahead has 7 modules. The first 2 of these are psychoeducational, and we recommend that all of our people who are interested in doing this program take these. So the first one is about understanding a brain injury, and the second one is understanding about behaviour. I mean, why a behaviour might happen, why it might be perpetuated, and what the consequences of that behaviour are in order to understand how better to perhaps manage. The next 4 modules are specific to particular kinds of behaviour, and not everyone might be interested in all of these behaviours. It might depend on the family member and the particular problems that they're experiencing. But these look at things like irritability and aggression, apathy or low motivation, acting without thinking and being impulsive, and having social difficulties. And also the last module is another one we recommend everyone takes, which is about caring for oneself as a carer. These use these firmly established behavioural principles that we know work in terms of changing behaviour. We use these colourful, easy-to-read slides, like you can see a couple of here on this as examples here, and there's also supplemental reading materials that people can download if they would like some extra information. But the actual information online is very simple. So I said it's based around 4 families. So this first family is Anne and her son John. So Anne introduces herself saying, "Hi, I'm Anne. About 4 years ago, my son John was attacked one night when he was out with friends, and as a result he got a brain injury and he was only 20. And although he's mostly recovered physically, he gets irritable and can be aggressive at times." And so we get to know a little bit about Anne and her son John as a prelude to looking at behaviours and the way we might be able to manage those. The second family is Jerry and his wife Sandra. So Jerry says, "Hi, my name's Jerry. My wife Sandra had her brain injury from a car accident. We were driving back from seeing our son and his family over Easter, and our car ran off the road." And so Jerry feels that the issues that Sandra has are mainly around sort of communication and social interactions, so that she seems to be back to normal but often has trouble saying what she's thinking or says things that don't make sense and so on. The third family is Jenny and her husband Tran. So Jenny says, "Hi, I'm Jenny. My husband Tran fell off some scaffolding in a workplace. 6 years ago he broke his back and had some damage to his spine, which makes him have tingling and numbness in his legs. He also had a brain injury, and she feels that he doesn't think that he's changed as a result, but she feels there's lots of things that he could still do, but he doesn't get round to it." And the last family is Ahmed and his wife Halima. And so Ahmed says, "Hi, I'm Ahmed. I've been having difficulties coping with my wife Halima after she had an accident when she was knocked over by a car travelling too fast. And now she often says and does awkward things and acts before thinking." So each of these families, we try to sort of represent different kinds of families, and each of these families may have more of one kind of problem than another. Each module that you get introduced to has a narrator. So this is the narrator who explains about the families, And there's also a psychologist, Angela, who is the one who talks to the families about the difficulties that they're experiencing and how they might go about perhaps improving the situation. So in the first module, the narrator has quite a bit to say and explains the kinds of problems that people commonly have with a brain injury, including these kinds of cognitive difficulties. And then in module 2, the psychologist actually starts to explain the basis of behaviour, why behaviours happen, and what sort of things might be possible in order to reduce the occurrence of the behaviour or change the behaviour or so on. And so often it's a situation where the families needs to think about, well, is there something that they're doing that creates the behaviour, or how is the behaviour triggered, and so on. So these are both, as said, general psychoeducational modules that we suggest everyone does. And then the modules move into these specific behaviours such as aggression and irritability. So this is the psychologist giving advice about that. And then apathy and low motivation, so the psychologist making suggestions about how one might deal with low motivation. And again, social difficulties, so advice and strategies to deal with someone who's having social difficulties. And acting without thinking, again, just working through with a particular family and the kinds of problems they might be having. And lastly, self-care. So this program was developed several years ago now, so with iCare's support. And so we ran, with iCare's support, we ran a pilot study to see how acceptable this program would be to families. So we had six family members who were happy to help us work through it. There were 8 weeks it took them to go through, and they were asked to comment on how acceptable and feasible they found the program, and also they completed some measures of mood and burden, carers' burden and behaviour. So overall, we found that the programs, each module took between 20 to 60 minutes to go through, so people varied somewhat about it. We can see here of the 6 family members, the majority of them found that thought it was useful, and they were very satisfied with it, and they felt they would recommend it to somebody else. So that was very gratifying. We also had them to complete various questionnaires looking at their mood and the strain they were experiencing in the family functioning and so on, and also challenging behaviour. And we can see that the majority of them had significant difficulties pre-intervention, and as you can see, wasn't a lot of change post-intervention. There were in fact 2 families who reported slightly worse family functioning. One of those families, the carer was in a very isolated and highly stressed situation, and was fairly pessimistic about the program. And the other carer didn't actually report any problems to start with, and wasn't really engaged or available throughout the program. So there might be particular reasons for that. And I think the bottom line is that every family is different, and whether or not this is useful for people will really vary depending on people's circumstances. The comments were generally very favourable. So what people were saying is, they really liked its simplicity, the fact that it existed and could help people who weren't aware. Another comment, I found the entire session informative. It covered a lot of things that affected me. People really appreciated that it was self-paced. They could do it in their own time. It was very flexible. And I think people even find some of the modules that aren't directly relevant to them still helpful, because it's still reinforcing some of these very general principles about how we can manage behaviour. And people really liked the fact it was quite concrete. And another comments people did make was that they actually wished it was available when they had first been discharged from, or their person had been discharged from the unit, because some of these people had been quite a long time post the injury, and they had felt they had sort of had to work out a lot of this stuff all on their own. Some of them felt like they already kind of had discovered some of these principles, but would have been really appreciative of knowing it earlier. So, what's next? So, again, with the support of iCare and also the National Health and Medical Research Council, we got funding to do a randomised control trial, which means that we can put we can actually put people into either the active treatment or into a waitlist control situation where they just wait for the treatment and see whether or not this treatment actually has some beneficial effects for them. We're hoping that this program will change the frequency and severity of any challenging behaviours that they're experiencing, and improve carers' strain, mood, and hopefully satisfaction with life, and also to improve quality of life and reduced health services. We ambitiously wanted to recruit 100 families. We're finding our recruitment's a bit slower than we'd like, but nonetheless, we're still recruiting, and we'll be recruiting from now until the end of 2023. That's supposed to say 23. Sorry. I think this might be the old version. Okay, so the program is for anyone in Australia, and in fact with New Zealand, in fact anywhere with the time zones reasonable with Australia will take. Adults, the family members need to be 18 or more. They need to have a family member with a traumatic brain injury and find that the behaviour of the family member is challenging and have access to a computer and internet. And also not in treatment for the challenging behaviour. And if people get involved, they just have to sign up and provide consent. They need to be screened, and they can complete the Carers Way Ahead online program. And this program also involves, at this stage, access to an expert clinician who touches base from time to time and is always there to help sort out problems if there's any additional needs. So that's it. That's how to access the program. Thank you. Yep. Sorry. Yep.
Thank you, Sky. And I'm sure if anyone has anyone that they can think of, do refer them to Sky's program, because it's been a long time in development, and a lot of care and work has gone into that program. So I can recommend it. So we have one more speaker before afternoon tea, and they're actually, I believe, online. We have... we good? His name is Peter Yu, who's going to be presenting our final paper. Tom Oxley is unable to present today. Peter Yu is going to talk to us about minimally invasive brain-computer interface for severe paralysis, first in human experience. And hopefully we have Peter. There he is. Welcome, Peter.
Thank you.
We can see you.
Great. Hello, everyone. It's great to be here. Tom sends his apology. Just a couple of disclosures. I hold stock options at Synchron, and the devices and the procedures that are described here are classified as an investigational device by the FDA. So we'd love to talk to you today about a solution that we've been working on. It's called a neuromotor prosthesis. It's our attempt to address some of the independence that are lost by, that are caused by paralysis, and we want to treat it with a device. So the issue is that paralysis is caused by a variety of causes, including stroke, demyelination, neurodegeneration, and it's causing a lot of economic and, of course, personal suffering of the sufferers. And it's not just from conditions, but it's also caused by other factors such as, movement disorders and injuries, and also amputees as well. So we want to reduce the problem down to restoring the lost bodily function. So in a non-condition or healthy conditions, we can generate an intent from our brain that gets transduced down to our limbs, usually the hand, and then we can usually press a button or interact with the digital devices. And now digital devices are ubiquitous, which really increases the independence for someone to communicate, work, and do everyday tasks. So for a paralyzed individual, the motor capability of being able to interact with digital devices is lost. So we are introducing a neuromotor prosthesis to restore this motor capability of being able to transmit the intent from the brain to an external digital device. So we are building upon years of neuroscience and previous work. So people have been implanting intracranial sensors, electrical sensors into the brain previously. So this is a work coming out of Netherlands. That's Van Stensel et al. This work was published in New England Journal of Medicine 2016. So this group implanted a variety, multiple sensors directly onto the brain by performing a craniotomy. So open brain surgery, they exposed the brain, they then placed these electrical sensors that you can see on the image on the right directly onto the brain, and recorded electrical signals while this completely locked in patient attempted to move her hand. They were able to pick out certain neural features that are well known in the neuroscientific literature, and they're able to distinguish the times where the user wanted to move her hand versus not, thereby giving her an ability to generate binary switch outputs. This person was able to then use a simple scanning speller, a raster scanner, and she was able to type by attempting to move her hand to engage with the letter that she wanted to type. So this was at about 1 character every 52 seconds, or 1 character per minute. So the important bit here is that this person used to rely on eye tracking, but she was having trouble using it outside, and it required a lot of calibration, and her eye movement was actually degressing over time. So this brain-computer interface system gave her a 24/7 access and a system that she could use outside to communicate with her loved ones and perform daily functions. And of course, that's on the left side of the spectrum, a very simple system. But on the other side, recording from the surface of the brain, also we can extract a lot of high dimensionality information, so more complex information. So this work coming out of UCSF, Chang et al., they're able to implant high density ECOG grids. So this is, again, surface electrodes inside of the skull directly onto the brain. They're recording high frequency information, which often you can derive more complex information, and using this system, they're able to generate a system where the patient could think about speaking, physically speaking, and they could decode speech directly from the neural signals with some help with some language models and machine learning as well. So using this system, this patient who's also nonverbal and paralyzed, able to generate or type onto the screen about 12.5 correct words per minute. Now this person is able to communicate using the system. Of course, this work is great, but from our perspective, how our work started was that all of these great advances in intracranial neuroprosthesis required craniotomy or open brain surgery. So we thought it would be very neat to utilize the blood vessels as a natural highway that gives us access to inside of the skull to introduce these electrical sensors, thereby negating the need for a craniotomy and reducing the health risks during the procedure. So as you can see, there is a natural pathway that stems from the jugular vein. Of course, we can easily access this without having to remove any skull or bone. And we can naturally progress the device up into the motor cortex area. So that's the top area that you're seeing. So then this gives us the benefit of being able to record these high fidelity neural signals from inside of the skull. The skull acts as a bit of a filter. So you can still detect these signals from outside of the skull by placing sensors onto the scalp itself, but the quality of the signal and the stability isn't great. So by approaching the problem through an endovascular way, we're able to record high fidelity signals without exposing the patient to risks of open brain surgery. Then we're trying to make improvements on other facets of the brain-computer interface technology as well. So you would have seen that they had these big machines and a percutaneous connection that's coming out of the head in the previous work that I've shown you. We're trying to really make this into a at-home usage system, not a research device. So this is what our product is developing towards right now. And the idea is to provide the patients with as many discrete switches output as possible. So perhaps it could be a given patient thinking about her moving her left hand and right hand would become two switches. And then we can output that as a very standard digital output. And the patients and the users can decide how to use those switch outputs in the way that they see fit. So an obvious example is on Apple devices, there are ways to control your iPhone and your iPad and whatever else using switches. And this way they could use that mechanism by thinking about wanting to generate clicks. So just would like to show you how we actually implant these devices. So we've managed to perform a early feasibility study of a patient N of 4 at the Royal Melbourne Hospital in the last few years. So the way that we introduced this device into the brain is as follows. So we do a whole slew of testing prior to the implantation to make sure that the patients have adequate stability and fitness, as well as the venous anatomy to introduce the device into the motor cortex. We perform functional MRI and other structural MRI and MR venography to derive these information. The key thing here is to identify the functional primary motor cortex and the anatomical marker that corresponds to it. Then we utilize a pretty standard interventional neurology procedures that are used in stroke and clot retrievals. The only difference is that we have to be able to deliver this device to a target. So we had to develop a way of co-registering this target and providing that to the interventionalist to be able to deliver the device to the correct place. As we described before, we introduce and gain access to the blood vessels through the jugular vein. Then we can navigate a series of catheters and wires, guide wires, through the sigmoid, this tortuous bit, through the transverse sinus, then into the superior sagittal sinus. These sinuses are robust dural vessels that is the main drainage vessels in the brain. So we use this as a natural highway to get into the motor cortex. So this is what it looks like during the procedure. It's quite hard to see, but this outline is the superior sagittal sinus. These are, the white line is the guide wire, and these are a series of catheters that's going over the guide wire to be able to get to the target site. Then once we get to the site, we unsheath our device. So again, the device itself is not very radio opaque, so it's a bit hard to see, but if you squint, you can see it. So this is the device coming out of the catheter, and the motor cortex is about here. And this is what it looks like once it's been deployed sitting inside of the blood vessel. So you can see that the lead of the device is sitting inside the blood vessel, and we're able to deliver the device near the motor cortex inside of the blood vessel. then we have a electrical transmission unit that the electrical sensor is plugged into, and everything is internalized. And that transmission unit sits inside of the chest skin, much like a pacemaker, and it wirelessly transmits the neural signals that our device captures in the brain out of the body so that we can process it and translate it into useful digital signals for our users. So this is just to show you that we're able to deliver this device inside of the blood vessel accurately. So this is the target area of the brain that we want to be recording from, and we're able to deliver the device right next to it using this interventional method. So some early results from our early feasibility study. So this was a clinical trial, as I mentioned, called the SWITCH trial with Professor Peter Mitchell and Bruce Campbell as the PIs. We recruited up to 5 patients with a 12-month follow-up, and this was primarily a safety study, but as a secondary outcome measures, we also looked at some of the efficacy measures as well. We noticed no significant serious adverse events. The patients did report, minor things like headache and a little bit of bruising due to the procedure, but we observed no thrombosis or any serious adverse events at 3 months and 12 months as well. The vessel stayed patent, and there was no reduction in drainage or anything like that across the 12-month period. And across the year, the device was securely placed where we implanted, and it did not migrate across time, showing that the device could be implanted safely up to a year in a stable position using this neurointerventional method. Onto the efficacy slides, you can see that our patients were able to only spend a very short amount of time in training to be able to use the system at home independently. So this little long line for the patient 1 is that we were learning ourselves, trying to figure out how to decode signals from the brain, because this is truly a novel signal. These sorts of signals have never been recorded from inside of the brain until this point. So this was a bit of a learning phase. Then once that phase has ended, for our subsequent patients, we're able to get the system up and running relatively quickly, and the patients were able to utilize the system at home without needing calibration by a PhD neuroscientist or other clinicians. So this is how our patients utilize the system at home. So the concept was, don't take away anything that the patient is used to. These patients are quite paralyzed. They have their own specific setups. So we wanted to introduce the brain switch to improve their normal usage. So in this case, we wanted to interface with an eye tracker. So the patient would look at where he would want to click and then use the brain click to engage with the target. So the white, you can imagine, is the brain signal, and it's like a switch going up and down. So to go back, the patient is scrolling down and wants to click on this button, which turns the light on in this room. So he looks at the target, thinks about clicking, and it makes the click, and he's able to control its environment this way. Very similarly, he can also do other things on the computer, because we've now given him a generic method of pointing and clicking, which then you have access to a full computer. So this is him typing, utilizing the same method. So he's looking at the letters that he wants to click and then simply thinks about clicking in order to make these clicks. And of course, we want the patients to utilize the system without requiring an eye tracker, because not all paralyzed individuals still have the ability to utilize an eye tracker. So we also devised the method of the patients being able to control the computer and type with the brain switch alone, with a special UI or user interface like so. So this work has been previously published in Journal of Neurointerventional Surgery and JNIS, if you'd like to go take a look at more details. But importantly, we have a Switch 2 trial, so the next phase of the trial, And we're recruiting right now. So again, Professor Peter Mitchell, Bruce Campbell, Robert Henderson, and Matthew Kieran and Sarah Lee all involved in the study. This is a Australia-wide study in Brisbane, Sydney, and Melbourne. The sample size is about up to 10 patients. It'll be, again, a 12-month follow-up study, and again, looking at primary safety outcomes of device-related serious adverse events, death or permanent increased disability, and making sure that the device can be implanted safely by looking at vessel patency and device migration. To be able to be eligible to participate in the study, we have a stringent inclusion exclusion criteria, which is all again on clinicaltrials.gov. So please go take a look. And we're looking for a variety of conditions that cause the paralysis. Again, so this is not just limited to people with brain injuries or ALS or spinal cord injury, but paralysis is the condition that we're trying to cover. This is the team that's the Melbourne on the left and our team on the right. And I want to leave you with a slide. This is from our first patient. So this is the exact moment where I was sitting next to them and we called Nancy over, so Graham's partner, and we wanted to show for the first time Graham being able to use his brain switch to type out a message to Nancy. So this is that exact moment that we're able to show that to Nancy and capture this wonderful moment. So, you know, for people with paralysis, the world opens back up if you give them the access back to a digital device, and we really think this can improve people's independence. So thanks for giving me the opportunity to talk to you. And if you have any questions, please email Tom directly or myself as well. Thank you very much.
Thank you so much, Peter. That was just fascinating.
No worries.
So interesting. I wish that had been around 30 years ago when I was seeing people who could not speak and we were just using Perspex boards. It's come such a long way. We're right on afternoon tea. So thanks very much for coming to this session. We've got one more session left, I think, after this one. So enjoy afternoon tea.